Yeah.
Good evening, ma'am. Shall we begin, ma'am?
Yeah, sure. Yes, good to begin.
Okay.
Before you begin, can I say something?
Sure, ma'am.
Dharmen is there? Dharmen? Is
Ma'am,
Dharmen?
sir did
Sir,
join.
Yes, ma'am. I am. Good evening,
Dharmen,
ma'am.
will you continue?
Yes, ma'am.
You
Why
will.
not you?
हाँ. So please chair today's session.
No,
Okay.
no, ma'am. No, 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 ma'am. Thank
Because
you. No, ma'am.
I will not be there. You are senior
Um,
most,
I,
and you
I,
have to do.
I think Arif is here, ma'am. Or I think he will continue for the long time than me.
Okay.
So
Both of you will be there, Arif and you. ठीक है?
yes, ma'am.
Okay.
So
Okay.
responsibility will given to the Arif, ma'am.
Okay.
Uh,
Okay.
okay, ma'am.
Okay.
Okay.
Okay, Simmy, you can start.
All right,
Simmy?
ma'am. Yes, ma'am. Respected dignitaries, my seniors, colleagues, participated teams from RINPAS, CIP, and all other gathered over here, a warm good evening and welcome everyone. Thank you for joining us on today's webinar organized by Department of Psychiatric Social Work, RINPAS, Ranchi. Family from batch 2019. Currently, I'm working as a program director and clinical psychologist at Serefe, Gurgaon. I'm also a consultant psychologist at an NGO named You Are a Wonderful Project. I'm very proud to inform that everyone that this is the 16th session in the departmental webinar series on Pragatya, the virtual learning platform initiated by Dr. Govinda Manji and Mr. Himanshu Singh, alumni of RINPAS. The first webinar in the series were conducted in June 2020, and the successful journey would not have been possible without a distinguished alumni, Dr. Nand Kumar Singh, Dr. Arif Ali, Dr. Dharmendra Singh, Dr. Bhupendra Singh, Dr. Prashant Srivastava, and Mr. Upendra Singh, and other alumni members of all departments of RINPAS, PSW, Clinical Psychology, and Psychiatric. Special mention to faculty members of RINPAS, especially Dr. Manisha Kiran ma'am, for her dedication for getting new speakers and interesting sessions in every webinar. I would like to mention a few guidelines before we get started with the session today. Kindly keep yourself on mute at all times. You might like to pin the speaker for full screen experience. In case you have any questions during the presentation, please type them in the question box in your Google Meet or YouTube control panel. We will bring them in the end of the presentation, and we will also have time for discussion at the end. Your active participation is essential throughout the session. Right now, I have everyone on mute to avoid background noises that may distract you from listening to the webinar. Firstly, I would like to express my gratefulness to Dr. Manisha Kiran ma'am, HOD and Associate Professor of Department of PSW Psychiatric Social Work, RINPAS, for giving me this opportunity to be moderator in this webinar. Today, we are organizing a webinar series and presenting our 16th webinar on tools of professional development, personal psychotherapy, and professional supervision. I'm indeed privileged to have an eminent convener today and respected Dr. Manisha Kiran ma'am, and this responsibility has been also given to Arif sir and Dharmendra sir by ma'am. To introduce Manisha ma'am, she's an associate professor and head of Department of Psychiatric Social Work. She's been a gem for mental health. Contributed her 24 years to the field in different ways, giving remarkable researches to the area and trained lots of students under her guidance and supervision throughout. Coming to today's topic, that is to tools of professional development, personal psychotherapy, and professional experience, professional supervision. Oh, I have also experienced it. I understand how the client would be going through, and I get this urge to speak to a senior or professor like I used to do in the past. So I feel today's topic is very crucial for a new mental health practitioner like me to get an idea of how the real world works, and also for already established practitioners who would like to get a new direction forward in their growth. Now, it's an honor for me to introduce and welcome our speaker of this evening, Ms. Shreya Varma, ma'am. Before the presentation begins, I would like to give a brief introduction of our speaker. Ms. Shreya Varma is a clinical psychologist and alumni of RINPAS batch 2014-16. She has worked in a wide range of healthcare settings since she completed her training and currently works at Sree Krishna Medical Research Center. She has worked at Sanjeevani Society for Mental Health, Fortis Healthcare, Symbiosis International University, and the YP Foundation. Other than this, she has been associated with various charitable mental health organizations, volunteering and educating in different mental health areas. For today's webinar, she will be sharing some of her experiences as a clinical psychologist in her private practice and the role of personal therapy and professional supervision in our practice as well, in her practice as clinician as well. So over to you, Shreya ma'am, and thank you for your time.
Yeah, thank you, Simmy, for this really warm introduction. It felt really warm to hear a colleague speaking about this. And at the onset, I really wanted to thank RINPAS and the Department of Psychiatric Social Work that they're doing this. And I thought it's a really wonderful opportunity. And I thought it's really nice that I'm getting to interact with my colleagues and some of my seniors that I have worked with and I had trained with. And while I've been working, I've begun to realize that the years that I'd spent at RINPAS have been really valuable for me to. I think when I was at RINPAS, I never understood the value of what I'm doing at the psychiatric hospital. But it's only after years of working that I've begun to realize how valuable that experience was and how it really helps to use those experiences that we've all had while we've been working to work with our patients, assess the mental state, and then move forward and decide how we should be intervening. So that said, today I wish to actually speak about some of my experiences that I've had. And I wish to talk about particularly the role that my own personal therapy and professional supervision has played in helping me grow as well, and which I feel are really important tools that we all have that we can use to, I suppose, elaborate our clinical skills and enhance our clinical skills. So I'll speak for about 45 to 50 minutes. And like I think Simmy said, if any one of you have any questions, you can type it in the chat box or the comment box and we can take it up at the end. I'll give a brief outline of what I'm going to be speaking of. So I'm going to be speaking mostly, I'm going to begin with the therapeutic relationship and what it means when we have a therapeutic relationship with our patients. And then move on to institutional settings as also relational settings. So I've also worked in a lot of, outside of my private practice, I've also worked in certain institutions. And I'll speak about those as relational settings. And then I'll speak about the therapist and our own experiences that we have and what does the therapist go through in the clinic, and move on to the role of personal therapy, and then speak about the many kinds of supervisions that are available to all of us, and illustrate all of these things through many cases that I've thought of. So like I said, I'll begin with the therapeutic relationship. So this is something that I think when we've all studied, we're all mental health professionals. So whenever we've studied therapeutic relationship, we've all studied these concepts that what does it mean when we have a therapeutic relationship? What does that relationship mean? And I think in that, when we're providing therapy, what we're actually providing to our patient is a relationship. So one of my supervisors had actually told me that when our patients come to us, they often come to us because they are having a lot of relational problems, no matter where their diagnosis lies. A lot of the patients that come to us are having issues with respect to their relationships in their own life, issues with with respect to their mothers, issues with respect to maybe meeting people, issues, relational issues. And therapy is also one such relationship that we offer to our patients. So in the therapeutic relationship, there are actually two people that are present. So there is the patient and then there is the therapist as well. So we are also equally present with our patient when we're providing therapy. So in this particular therapeutic relationship, I think often when we work as clinical psychologists, what we allow our patients to do is to use us. We allow our patients to use us in this relationship. And we think about how is the patient using us in this relationship and how am I reacting to this particular patient. So for instance, before I get into this case, so the two questions that I think all of us work with and that I particularly work with when I work with my patients are, why is the patient doing this and saying this? And why is the therapist saying this and doing this? So, for instance, this particular case had her session scheduled at 3 p.m. And she messaged me and she said she won't be able to come in by 3 p.m., but she'll actually come in by 3:15. And 3:15 passed. She was still not inside the room. So I actually went outside. I opened the door and I saw that she was sitting there. And then I asked her to come inside. I said, hey, why don't you come in? And as soon as I did that, I actually began thinking, what made me want to do this? What made me want to get up and open the door for her? What kind of a person is she evoking in her relationships? And what does this mean about her? And what does this mean about me? So these are the kind of, I think, questions that we work with to be able to help our patient understand their own relationships and where they're getting stuck. Another patient, for instance, I had, she began speaking to me. I'd been working with her for about 7 to 8 months, and she began speaking to me, and it really left me really confused because she was speaking about her relationship and that she's broken up and that she felt so many things. And in that moment, she was also speaking about, she brought in one dream. She said she had a dream of a hat, and then in the dream she was trying to figure out what the hat meant. And then I asked her for her associations and if she remembered anything, and she actually said she doesn't remember anything. So when I brought this case to my supervisor said that, look, she's using the space of the clinic to not make meaning, but she's actually trying to do that in the dream. And with her, when I was sitting with her, I also felt baffled. I felt like my own ability to think was paralyzed. And I think the interesting thing to think what is she trying to communicate? What are the symptoms trying to communicate? That ability, I think, was completely paralyzed. I felt just as confused as her. And she had had many early losses in her life. And moment, her and me experienced what must have been going through when she was young, and also what her parents felt when she had the early losses, that it felt completely baffling and completely puzzling. So I think these are moments to help the patient to understand that these things happen and they seem to be happening in your everyday life. Now, I was speaking about the therapy relationship as also a relationship, that there are two people present. There is me as a therapist, and so many things are happening to me while I'm sitting with my patient. But there's also my patient who I'm in a relationship with. And often, I think when I started working in institutional settings, I realized that institutional settings also offer one particular type of a relationship. So I have worked in a college as a counselor, and I had started working in this college after I'd completed my training as a clinical psychologist. And what I realized is that the workspace is really different from, like, for instance, a private clinic. So I have, like, for instance, colleagues who work in halfway homes, who work in rehab centers. So these are really different settings than a private clinic. And I think the difference is that your workspace, for instance, in a college, my workspace is the same as the workspace of my patients. Often I walk into the same time to the college as my patients, and I'm running to get to the office because there is a time for me to get in, and so it is there for my patients as well. Often in a college setting, we're also doing a lot of group work. We're going in, engaging with the class, speaking about particular topics to help facilitate thinking in those areas. We're doing educative sessions with the students. We're doing educative sessions with the teachers. I'm walking into the same library. I'm walking into the same canteen. And I think the way me and my patient relate to each other changes because of this. So I'll discuss this particular case first because it really, for me, illustrated how in certain institutional settings, the nature of your relationship with your patient completely changes, and the way you do therapy then has to be rethought and reinformed because of the institutional setting. Because the institutional setting also provides you, one of my colleagues had actually said that in each new setting that we're in, the therapist and the patient are both being born at the same time, and it's a role that we're playing. So I think this is something that I realized when I'd begun working in the college setting. So for instance, for with this particular case, I had worked with her for about 4 months, and she had an early history of sexual abuse, childhood sexual abuse. And we met for 4 months. We were beginning to think about how these things are impacting her relationship, how I think because of the abuse, all of us have worked with personality disorders as well. So a lot of the times it's so hard to, I think, contain your emotions and be feeling like my body can contain these emotions. So she was, I think, going through similar things, and we were beginning to understand that these are things that she has experienced really early on in life. And often, I think, with sexual abuse, for instance, it's really hard to accept that you've gone through this. So with this particular case, I think she had reached this stage where she was beginning to speak to, like, for instance, her parents about the fact that this happened to her, speak to her boyfriend about the fact that this happened to her. And I think that shifted something internally inside for her. But after 4 months, she abruptly stopped coming. So after 4 months, when she stopped coming, I had, after the first session when she did not come, I had followed up with her and I'd asked her, hey, you have missed your session today. I'm looking forward to meeting you next week at the same time. And she didn't reply back. The next week, I again messaged her. She didn't reply back. And then after that, the third week, I messaged her and I said that, okay, it looks like you have dropped out. But if you would like, you can always contact me and we'll continue our work together. And she didn't reply back to me for a while. And after that, I realized that that I'm sitting in. The work is the work of the clinic is the college, because I'm still going in and doing therapeutic work in group settings. I'm still doing educative sessions, and she would still see me everywhere when I'm seeing her outside in this workspace. She would see me, for instance, I still remember she saw me outside in the canteen. She saw me when I was doing one of the sessions, and every time outside when she would see me, she would still smile at me really warmly, and she'd say, "Hi, Shreya, ma'am." And it was really confusing for me because the warmth, there was so much warmth, but it felt like the relationship that I had with her, the therapeutic relationship, was completely broken. And I think this warmth and confusion that I felt was probably related to my work with her and what she was evoking in the relationship with me. And it meant something about her own experiences in life. But I think more than that, what I wanted to speak about through this case is that the nature of your relationship is so different, because I think the patient also looks at you differently depending on the relationship that you have with them. And I think those boundaries. Now, I wanted to speak about another case, which I think for me was an important illustration of how I think in the previous slide I showed that sometimes in college settings we can't be doing a lot of depth oriented and insight oriented work. We can't be often in a lot of these settings. We are like one psychologist for 500 students. So even if you have a clinical patient, I think you can't be doing work which is going to invigorate some kind of energy inside, which is going to leave the patient feeling so fragmented. Because I think when we begin to think about experiences that we have had in our lives, we also begin to feel really disturbed. And this particular setting doesn't allow that. So I had, for instance, a case uh, who was uh, who was suffering with psychosis. And to my surprise, I was working, my supervisor at the time was a psychoanalyst, and to my surprise, she had told me that, Shreya, with this particular case, you should not. So I was trying to think, I was trying to push her to think about the fact that she had been through something in her early life because of which this was happening. And she told me, Shreya, with this particular case, you should not be doing that, especially because of the setting that you're in. You, I think, cannot be doing this kind of a work. So I think in that particular setting that I was in, because of the setting and because of the condition that she had brought in, the only kind of work which would have helped her was a structured therapy where I made goals for her, like for instance, semester goals. What would she have liked to do at the end of the semester? Break it down into tiny bits so she is able to work with it gradually, and keep a this is where I think our assessments come in use. Keep a check of it so you are also able to assess whether this is something that she is able to use in her life, whether it's improving or not. So I think for me, this was a huge learning, because what I realized is that with each new patient we have to invent ourselves as therapists. We have to be a new patient. We have to be, well, a new patient. We have to be a new therapist with each particular patient. And I think my slip was that sometimes with each new patient, we also feel like a new patient ourselves. We begin to get in touch with different parts of us where we feel like patients. So I think that's the importance of the relationship, that no matter how we work, no matter what kind of therapies we do, we always actually, all of us as psychologists, we're always aiming to provide one relationship to our patients where our patient can come back to us and use us and realize that this is a good enough person who we can fall back on. And I think often the idea that we're given, or when, for instance, I finish my training, the idea that we're given is that we as therapists are people who know everything. We know how to fix a patient. We are people who are sitting, the patient is speaking, and we can quickly, you know, unwind the yarn of wool and figure out where one thought is coming from, where the other thought is coming from. But actually, I think the truth is that we feel really messy ourselves as therapists. When we're working with our patients, I think My colleague Simmy also said in the beginning when she was introducing this particular webinar that we all have this experience. We all work with our patients, and every time we work, we're like, why is this patient not understanding what I'm trying to tell her? Why is this technique not working? What am I doing which is not helping this particular patient? And our own experiences are actually really messy and knotted. When we sit in front of our patients, we feel, I think a lot of feelings are evoked in us when we sit in front of our patients. And well, before I move on to this slide, I thought it's really important because for me, this was also something that changed, because I think the idea that we're given is that we know what to do, but the only thing I think that we know as therapists is that we do not know, and that's what we work with when we work with our patients, because we work with the fact that I don't know what's going to happen, but we stay with this messy feeling and we work along with our patients to build on it. And I think this particular image, but I think particularly with the times that we're living in, illustrates that so well, because currently we're going through the trauma of the pandemic. We're going through something which is so traumatic. Worldwide, there is economic loss. There are so many deaths, and we're living through this harsh period where we're having to not be able to meet people as frequently. We're not able to meet our own parents, maybe. And I think in this particular time, of course, the patient is maybe going through something even more. They are being impacted more. But both the therapist and the patient are in this together. And why I liked this particular image was because I think sometimes we don't realize that we as therapists are also really vulnerable, and we go through the same vulnerable experiences that our patients speak about. A lot of us have had these vulnerable experiences and these things that our patients speak about which feel so traumatic to them. We've also, if not to that intensity, we have felt these things inside our minds as well. And I think this is something that my supervisor had said to me, that when we actually work with our patients, we actually offer observations. Our observations are something that we notice, that I think this patient seems to be doing this. And we offer that to our patients, that I think, you seem to be doing this. I think this is something that you're not able to look at. I think this is something that you seem to be going through. Or even if we're trying to reflect their feelings back to them, I think in this particular moment, you're having really a difficult time holding on to a sense of stability. And what my supervisor had said is that when we offer an observation to our patients, we're actually offering our patients a part of our own mind. And in doing that, we're becoming really vulnerable. Because actually, when I offer this observation that I think in this particular moment, you're not able to hold on to any sense of stability, I can only offer that because I'm able to connect with that feeling in my own mind, and I offer that to my patient. So I am just as vulnerable when I'm sitting with the patient. And I think that's the role of therapy. When we're all working as clinical psychologists, we all, and I know there are other mental health professionals here as well. I really feel all of us who are in this line of work, we have all gotten into this line of work because we have a desire to help others. We want to help others. And I think this desire is coming in because somewhere we want to be helped ourselves. And I think, like for instance, I have studied psychology. So, and a lot of different subjects, like which are under the stream of mental health professions, would be similar. The definition of these subjects is that you're trying to understand the human mind, body, and behavior. And I think a lot of us have gone through experiences where there are things stored inside our body which we are not able to link with our own mind, but we're doing this in this cut-off manner by studying this subject. So we are actually hiding behind the garb of theory and saying, okay, and a lot of us do this as psychologists. Okay, you know what, I am rationalizing at this point and it's happening because of this. So even while I was studying, and even when I work with clinical psychologists, that's the beauty, that we're always thinking psychologically. We're all psychologically minded individuals. But I think sometimes we're actually hiding behind the garb of this theory because we have gone through something so I think we have all had experiences that we're trying to think about in our minds. And this is why we have gotten into the profession of trying to help other people. And I think that's really integral for us to understand, because only when I think we can understand that there are things that I have gone through, can I then notice that about my patient as well. I think another thing that therapy really helps with is understanding the meaning behind your own patterns in relationships. So what that means is, like, for instance, I may have had a life where one of my parents might have had a chronic illness, chronic physical illness. And I might get a patient who tells me that while they were growing up, one of their patients had a really chronic illness, and then they moved around a lot. But this is nothing that's a stressor for the patient. This is not one of those factors which has led to the illness. But I am seeing it as something that's important for the patient, because maybe this is something in my own life that's happened. So I think if we're not able to, I think what we're able to do in therapy through a lot of the work that we do is understand what I have gone through. And like, for instance, I have been to two therapists, and I've been in therapy for a long time. And I think what that provides all of us, whenever any of us go for therapy, what that provides us is a space for vulnerabilities to feel held in a relationship. Like, I feel like I've had two relationships where I've been able to experience the feeling of being held, and that allows me to feel held with my relationships outside the therapeutic relationship as well. And I think that changes the way in which you provide therapy, because you're able to provide a similar holding relationship and hold your own vulnerabilities to your own self. And I think that's the integral bit with therapy. I think that's why it's really important to be going for your own self work. I think I feel no matter what kind of therapy you're doing, even if it's eclectic, and I while I've been working, I've begun to realize that these different therapies are just names. Eventually, we're not working with these names. We are working with our patient in the clinic, and these are things that have been written, but they've written about a relationship. They've written about different kinds of relationships in which either you're more authoritative or you're more empathetic. So I think, because we work with relationships and because we're present, it helps to be in your own therapy. I think another thing that has become a really important part of the way in which I practice is to be engaging in these kinds of things. So, for instance, personal supervision, group supervision, and peer supervision. And these are available to all of us. All of us, there are people who provide personal supervision. You can contact them. There are people who provide group supervision. There are senior clinical psychologists who provide group supervision. And you can also form your own peer groups and discuss cases. So I think when I began taking supervision for my cases, what I'd realized is that Now, I have trained as a clinical psychologist, so I can only speak about my own experience. So I feel like as clinical psychologists, we've had a really rigorous and an intensive training. And we have a lot of things in our theory hat as therapists. But when I began to take supervision, what I began to realize is that my supervisor could actually help me link theory to practice. That's something that uh, was not easy and is still not easy, because, like I said, it's easy for all of us as mental health professionals to hide behind theory. And I think what it's helped me do, and I think what supervision eventually helps everyone do, is to be able to grow your own capacity to reflect what you're doing with your patient and grow clinically, evaluate the clinical material. Because I think when you're working with somebody else is helping you look at what could be done differently. What are you doing? What did you say? How could you, what kind of words can you be saying? And as you go through this, you begin to understand small nuances of things. I think our training as therapists is something that continues even outside of our professional training. So these are things that help enhance our skills slowly as well. And what I have realized when I've been working with my supervisor is that I think these things also not only help you grow professionally, but I think they also help you grow personally. So for instance, I may be a person who has had difficulty saying no to people, and my patients may be calling me at odd hours of the night, or I may have one particular patient who wants to speak to me on the phone and always calls me on the phone. And this might be something, speaking to her might not be something that's helpful for this particular patient. It may not be helpful to speak to her over the telephone. It might be better if we're able to target what she's talking about in the clinic and make her come there. And if I had difficulty saying no, I think this is something that I can easily start doing with my patients. It may not mess my own relationships up with my patients as well, and I think that might not be something that's helpful for my patient. So I think our supervisors also help us grow personally when we're working with them. Um, I'm going to be briefly speaking about this, but I'll illustrate the kind of work that one has had. And I think talk about what these supervision formats for me have been like. So another thing that I've been doing is I've been engaging in clinical seminars and group supervision. It's the same thing. So it's called a clinical seminar, but for me, it also feels like a group supervision. So what happens is that I meet a really senior clinical psychologist, and then I have 4 other clinical psychologists with me, and we discuss one session at a time consecutively. So I present one session, and then the next session that I have with the supervisor, I bring in another session with the patient, same patient. And I think I think this is actually a really helpful tool to, this is really different from personal supervision. And it really helps, group supervision really helps because you're actually able to see how different clinicians work and how different clinicians are thinking about your patient. And I think like for instance, uh, if there's a group of 4 people, I might not be somebody who has many male patients, but I might have a colleague who predominantly has male patients, and my supervisor discusses many male patients that my colleague has. So I think through the supervision, you're able to understand a lot of the different kinds of patients that you have, and you can see how they think. that come in, and a lot of the you're able to learn a lot of clinical material. I think you're able to reflect how different psyches work, how different people work with different patients. And I think for me, the most important feeling that I got was initially when I started working, I used to feel like as a clinical psychologist, I'm alone. For some reason, I felt like, and I think we often end up doing a lot of one-on-one work with our patients, which increases the sense of isolation that you feel. But what I realized while I'd been working in the group supervision was that I have so many of my peers, like for instance, all of you are here with me thinking about these things together. So when I used to present my patient, I used to feel like, okay, this is what I'm going to do. And I used to feel like I'm not alone. And I think that with the driver. He's coming in this particular, he's going around, he lives here. So she began to make me think about how I was colluding with the patient's world, not being able to think something differently. And I think what I began to realize eventually is that we feel a lot of hate for our own patients. And I think this I realized with this one particular case, because I think for me it was quite frustrating, because I met a patient and it felt like the work is not going anywhere. It felt like whatever I was doing was just coming in and evacuating the space, just filling the session with something which is meaningless, and I'm not able to add meaning. I'm not able to help him build a meaningful life. And I think that really frustrated me. That really made me feel angry in the work that I was doing. And it's so hard to actually accept that we feel these things for our patients. I think it's so hard to accept that we feel sometimes we can't work with patients. It's so hard to work. And I think for me, what began to happen is that I used to sit in the seminars initially and used to participate. My colleagues and my supervisor are people who are outside who can't understand the work that I'm doing with him. But eventually, I think while working with my supervisor and with the colleagues that I had, I began to realize that actually I feel really frustrated by the fact that we talk about these things and the fact that I'm trying to offer some new kind of thinking and some new kind of intervention is not going in. And I think the fact of matter is that when we work in therapy, our work is to be offering the truth to the patient, no matter what we're doing, even if we're telling our patients that I think you should at this moment try to look for a job, or you should at this moment be doing this. We're offering the truth and we're trying to speak the truth. And this feels like such an easy thing to say, that there is no truth without kindness and no kindness without truth. But actually, it's the hardest thing to do. The hardest thing to do is to accept the truth that I cannot tolerate some of the feelings that I feel with my patients when I work with them. And that is the work that we do as therapists. The work that we do is unbearable because our patients go through feelings which are so unbearable. And in that moment, I think the only truth that we are able to offer our patients, which I, I think is the only thing that we can hold on to, is to say that this in this particular moment feels so unbearable to you. And I think that's when a shift happens, because I think till we realize we're feeling something, like for instance, when we work with uh, anxiety, anger management, these kind of things, the first thing we try to do is to help the patient understand that you do feel anxious, you do feel angry. And I think if we're not able to understand that sometimes the work feels unbearable and that we could be uttering truths like, I think this to you feels unbearable, we're not saying the truth anymore and we're doing something which is not kind to our patients. So, I think these are just a few more cases where I wanted to speak about the kind of feelings that were evoked in me. So this is another case that had and now I feel I felt really like, okay, I've been working so steadily with you. This so in the completely are you feeling angry at her or do you want to help her? You can't be feeling both things at the same time. And I think sometimes it's our own, like for me, it was my own inability to realize that in that moment I felt so angry that made me want to intervene differently. I think all of us have studied this, that we really have to be wary of our own body language as therapists. And I think the fact that I'm leaning in so much, leaning into her space, also seems to be coming from how I have these feelings that are evoked in me because of maybe my own experiences in life, which need to be held, which I need to think about in my own time. Now, this was another case that had come to me. This was a case that was referred to me by a psychiatrist, and she had come in with symptoms of feeling paralyzed, and she would just completely not be able to move. And for me, I think I started working with her and I started wanting to figure out with her. I started wanting to make her understand that she's like, what is a secondary gain for her and why is she doing this. I started wanting her to understand why she's doing this, and it was so frustrating for me because I was like, wow, like why is she doing this, why is this happening where she suddenly begins to feel paralyzed out of nowhere. It's so frustrating. And so the first couple of sessions that I spent with her, I just kept questioning her that, oh, this is happening, oh, is this really happening. And I went back to my supervisor, and my supervisor said that, Shreya, I think till you genuinely believe that she's going through something which is painful, she is dissociating, and she probably at some level is feigning this, but till you genuinely believe what she's going through, I think you will not be able to enter this relationship, and you will not be able to take her in, and she'll not be able to take you in. So what you need to do is to decide whether you're able to work with this or not. So I think through these cases, I actually wanted to speak about the fact that we do feel so much hate. And I think it's important to recognize and accept this, because a lot of times also when unknowingly we feel angry at our patients, I may end up turning up late, I may end up ending the session 5 minutes early. And these are things that all of us do. Even after so much supervision, so much therapy, we can still be doing these things because it is hard. But I think we have to begin to notice that actually we end up doing these things which sometimes impacts the way we're working with our patients. So I wish to now speak more about this particular patient. So like I said, I used to take this patient back to my supervisor and the group that I had. And what began happening is that I would meet this patient, and this patient would ask me, he would sit in the clinic with me and he'd be like, yeah, this is happening. And now tell me what to do. Tell me some tips and techniques. And I'd quickly go back whenever my turn to present would come. And I'd quickly go back and I'd say that I parrot the same words. I didn't consciously do it, but I parroted the same words to my supervisor. Okay, this is happening between me and him. Now tell me some tips and techniques. Tell me what to do with my patient. And I think it was only after presenting when she made me notice that you're doing the same thing that your patient is doing, that I began to realize that I had some expectations from her, and that he has some expectations from me, and these are things that are happening. And maybe these are also happening because he has expectations from his own life. People have expectations of him in his own life. And I think like for instance, one day I had a presented this patient, and then I went to sleep and I had a dream that I'm having a session with this patient, and I'm saying everything that my supervisor had told me. I have realized everything, and there's no difficulty that I'm having with this patient, and the session goes smoothly. And I told my supervisor that, look, I had this dream after I spoke to you. I ended up having this particular dream about this patient. So my supervisor said, wow, like so many expectations you have that suddenly, I will give you the answer and the key to suddenly let there be no anxiety and difficulty. Suddenly the session will become smooth. And I think these are things that are a part of me, but I think these are also things that are being evoked in my work with him, because these are things that are a part of him as well. And interestingly, after this, we spent a lot of time talking about, for instance, he would come in and talk about the fact that his family members have so many expectations of him. His family members expect him to be doing things differently. And I think if I not use my relationship with my supervisor and realize that I had so many expectations from her, I would have not seen that he also has expectations of me. And he also feels like so many people have expectations in his own life, which is making him feel so overwhelmed. And I think what I've realized while I've been working is that often when we work with our patients, we work with two hands. So we work with the ability to understand, and we work with the ability to empathize with our patients and to understand what they're going through, but we also have to be able to think with the patient and to understand what they're going through and to enable them to think differently. And I think that's why we're doing things with both hands. And I think often when we study psychology, or a lot of us learn, as psychotherapists, where kind of a parent who is really we have to be both the mother and the father, and actually supervision allows this to happen. So for instance, if you look at a mother and a child, now mothers when they've just had their baby, I think the first year of life is really difficult for the mother, where we've all read about the kind of difficulties the mother who just gives birth has. And often it's really difficult for the child and the mother to figure out how to be doing things together. So for instance, it's really difficult for the child to understand mother and the child gets stuck in. And I think it's the father who comes in and who says, why don't you do things differently? And sometimes it's the father, and it's the father also could be anybody who's a third. I think anybody who's a third person who is coming into the relationship and saying, hey, why don't you try this? Like between a mother and a child, sometimes you have older people coming in and telling the mother, try saying like this, why don't you try doing this differently? Or between a mother and a child, the father comes in and says, why don't you try to delay giving him treats? Maybe that's going to change. So there is somebody else who comes in and intervenes and helps the two people get out of stuck patterns and relationships in that particular relationship. And I think that's what eventually supervision really helps us all to do. In whatever therapies that we're doing, we're actually trying to think with the patient. So even if we're doing cognitive therapy, I think my supervisor had said this, that people often forget that in cognitive therapy there's a C, cognition, and we're trying to arrive at metacognition. We're trying to arrive at thinking about thinking, and that's what we end up doing in depth-oriented therapies as well. So whichever therapy we do, we're always trying to think about something and offer intervention to our patients so they could be doing things differently. And I think what supervision helps us do is to internalize the voice of this particular third, so we can be using our own mind and our own ability to work with our patients. So I think that's what I want to briefly speak about. I know it is almost, I've spoken for about 45 to 50 minutes, but what I wish to speak about is how therapy is the relationship, and we as therapists also feel how could we be using our own experiences when we're working with our patients. And to be able to use our own experiences, is the role of personal therapy. Personal therapy is the first step to understand our patients and then to continuously be working in supervision with the work that we do with our patients. So I'll stop for now. I think what we could do is take up any questions that people have.
It has been actually an overwhelming and insightful presentation. There have been so many questions, like I mentioned earlier, also doing the private practice that you keep on going through, how you need to go forward, what should I do next. So I think you have answered a lot of questions already, and it will definitely going to help newcomers like me and also senior mental health professionals in their own journey and growth of healing. Let me see if we have any questions in the chat box. Many people have acknowledged that the presentation is, Madhu ma'am has acknowledged that it's been an excellent presentation. Some people have mentioned about where they are from. Okay, so we have one question from Sadia Khan.
Yeah.
They ask, what to do if we don't have a supervisor like you had? Could you kindly, like even I have this question, how do you decide when to go for supervision? Like how do you decide who should be a supervisor and where should we actually seek supervision from?
I think there are actually, so firstly, I'll tackle the first question. There are three things that have come up. What to do if we don't have a supervisor like you had? How do we decide whether to take supervision or not? And how do we find a supervisor? So I think I'll speak about the first question that I think Sadia had. So
Yes.
I think what I have realized while I've been working is that when we work with our supervisors, our relationship with our supervisor is also a relationship. So I think no matter what kind, I think no, it would be hard to. I'm not sure what that question means, but I think that feels like maybe that supervisor might not be as helpful. And I would find that really hard because I think if we continue to work with our supervisor and give it at least 6 and see how the supervisor is helping you. I think for me as well, it wasn't easy for me to develop a relationship. Like I said, initially when I began presenting, I used to really be skeptical. I used to feel like I feel so many different things with my patient. My supervisor is saying something and I don't think this group understands. So I think it takes time for the relationship to develop. So I think if you're feeling like your supervisor may not be doing the kind of work that somebody else has offered somebody else, I think wait it out and see how the relationship develops. Because like I said, you're working with a relationship and then understanding your relationship with your supervisor to help your patient. And when to decide when to seek supervision, I honestly feel that we can be doing supervision at any point. What stops us from seeking supervision? We have finished our training. We are so skilled at working with our patients, but we can still enhance the skills that we have with a really senior person who is there, who has so much more experience, who can help me understand how to work differently and what kind of things that I could be doing. So I really feel when to start now. Why not start now? What's stopping you from contacting somebody? And how to find a supervisor? I think you have to for instance, I know a lot of the colleagues that I have had, they've tried to figure out the kind of therapies they'd like to do and the kind of work they'd like to do, and they've found senior people in the field and gotten in touch with them. So I think you have to find actually like at conferences and workshops and teachers, we have to, I think, ask people for a supervisor. But like, so I've been working in Delhi. So if people want to know who they can work with in Delhi, I would be able to help put people in touch with people in Delhi. So I think that's how you kind of find a supervisor, by understanding who is working like you, understanding what kind of therapy you'd like to do, and then figuring out a person that you'd like to work with. But I think what you could do to begin with is to find a list of people whose maybe style of work you like and contact them, or contact your own colleagues who are taking supervision and ask them, who can I contact?
Definitely. We can do like chaining whoever we know in the different cities, and if we know or where, and like you said, meeting in conferences or seminars, that's a very good idea that you have mentioned. Uh, we have another question by Dr. Benny asking how to guard our thoughts and emotions doesn't mix with our therapy sessions. What are the precautions to be taken?
How to guard our thoughts
and emotions, uh, which should not mix with a therapy session. Like I was talking about earlier, like sometimes when I am seeing a client, I feel those emotions that I have also experienced those emotions earlier. So how do I keep inside me and not let it hamper or affect the session that I'm or the client that I'm dealing with? So what are the precautions that needs to be taken? I think that's similar to what you were saying, frustrated and being angry. So how do we actually contain those emotions?
I don't think there are any tips and techniques like this to actually, I don't think I can be telling you, like, I think you should, in that moment start counting backwards to 10. There is nothing like that works. But I think, like I said, we have feelings as well. And I think in that moment, what we need to understand is that maybe these are experiences which we have had for some reason. For instance, with the patient that I spoke about, where it felt like he's two different people. With that particular patient, I felt so frustrated, and it might be because of things that I have gone through in my own life. So I think what we need to do is to address these issues in our own life and look at where this feeling is coming from. What I think the first thing is to notice that something is happening. I am feeling angry. Some thought is getting in the way of the work that I'm doing with my patient. And the minute that we've noticed that, then think about, why am I feeling this? Where is this feeling coming from for me? And why do I feel this with this patient? And what seems to be happening with my work with him? Often a lot of our patients, I think it's not like they're doing things which I don't think if we feel angry, it's a bad thing. But I think it's just that we need to acknowledge that we feel angry, and often these are things, for instance, that are happening in their own lives. So for instance, I spoke about that one patient with whom I felt confused, felt like I'm not able to think. So if I'm feeling a particular way, like I said, I think start thinking about what in me is making me think this, and what does this mean about my patient? Who am I becoming for this patient in this particular moment? Am I becoming somebody that they've had in their life previously? So I think, those are things that you could be doing.
That could eventually be one of the reasons that we seek therapy for. That could be one thing that we can discuss in our personal work. So I feel like you mentioned, supervision and personal therapy goes hand in hand. So we can keep on taking supervision and we keep on dealing with our own emotion as well in the therapy work.
Yeah, thanks, Simmy. I'm glad. Yeah, that's what I meant to say.
I remember the conversation, so I could gather that and comprehend.
Yeah.
So, if there's anybody who would like to unmute themselves and ask the question directly with from Shreya ma'am, feel free. And okay, we have few questions. So Bhupendra sir is saying, well explained. He has few questions. How do you deal with transference and counter transference? That first question. And second is how someone manage or get his or her work supervised in case he or she is alone in the locality.
Uh, so I'll speak about the second question first. I think the beauty of the internet is that now we have also live abroad. You know, we can all actually contact supervisors who are clinicians who are outside, who want to help people in India. So even if you're, I think, alone in the community, find, and a lot of people actually, sometimes my supervisor, I have phone conversations with her when my internet doesn't work. So find a supervisor who you could all be speaking on the phone. We feel alone as psychologists, but we're never alone. We have peers, we have seniors, and we have other people as well. And I think the second thing was, how do you deal with transference and counter transference? I think these are things, like I said, these words feel really heavy, transference and counter transference. But like I said, if we begin to think about the fact that the patient does something to us, why is the patient doing this and why is the therapist doing this? So for instance, in that one particular moment when my patient came in late, I went outside, I opened the door and I asked her to come in. When we read about transference, it's often described as, wow, past feelings projected onto the therapist. It's so many like uh, fancy words, but I think in the moment when you do therapy, you're not working with these fancy words. In that moment with my patient, something made me want to get up. And I think for me, what was important was to think about, why does she do this in her relationships? Why does she make people want to help her, want to go out of their way to help her? And it's possible that she has had experiences in her life which do this to her. So think about that with her. I think sometimes you feel like I think sometimes you feel like you really want to help your parents, or you really want to help this person that you've had in your life, and maybe you're doing this outside, and at least I do once a week or twice a week work at most. So I think in this kind of work, you can also sometimes be speaking about our own relationship that we have with our patients, that you and me seem to be doing this, you and me are doing this particular thing. So transference, counter transference, these are all such fancy words, but largely I think in the seminar today I have spoken about mostly my own experiences and the experiences that my patient has had. So how would you deal with it? You would deal with it by speaking about it, by looking at it, and by understanding why am I feeling things, and how can I be working with the patient differently, or why are these feelings being evoked?
I think you have very well comprehended the answer to the questions. We It's 7:20. We can take one more question if somebody has. One last question if somebody has. We can take a question. I think by and large, it looks we have covered all our questions. So I think it's not time for vote of thanks. And since we have Manisha ma'am with us, I would request Dr. Manisha Kiran ma'am to share her thoughts and present vote of thanks.
Simmy,
Yes, ma'am.
Simmy, it's Bhupendra. As you said
Okay.
that you still have a slot for one question.
Yes,
Just I would like.
definitely.
Uh, thank,
Definitely.
thank you so much. Actually, I just wanted to clarify my first question. It was not about the overall transference or the counter transference. I was just wondering that her experience for these two fancy words, either she faced or not, and if she faced, then how she managed. As she was explaining her experiences in a very elaborative and exploratory manner. So I was wondering that I faced a lot of time, and yes, although whatever it is, but I face both the terminologies in my that short life of this clinical practice. So I was just wondering how she felt, and if so, would you like to respond on it? That's it. It was
Yeah,
not
sure.
about the overall.
Yeah. So I think I'll speak about the patient that I presented over a period of 2 years. So with this particular patient, for instance, over a period of 2 years, the experience that I had was that I felt like he's two different people, and that I felt angry, and it was nothing that was easy for me to notice. I felt like initially when I started working with my supervisor, I used to feel like I didn't even recognize that I feel so angry at my patient. But I think that's I think why I've been stressing on supervision, because our supervisors really help us understand what we feel, and if we're actually able to also notice that we feel these things inside ourselves, then we notice it. We notice that we are feeling angry, we are feeling frustrated, and we think about what that means. Maybe it means that uh, this patient has had a life which largely has felt empty, and which leaves him feeling frustrated. So use these moments that we feel in our relationship to talk about what our patients are going through, that maybe you also, maybe you're going through something which leaves you feeling so frustrated. I think sometimes they end up putting feelings which inside us, which are also true about them, but that's not always the case. I think that's why I said you have to work with the relationship. So with this particular patient, for instance, with this feeling of frustration, I think it was probably to do with how frustrating it is to sit with the fact that these are empty sessions. And I think with personality disorders, for sure, when we work with our patients over time, there's so much emptiness, and there's so many of these feelings of emptiness that we work with. So you talk about the fact that it feels so frustrating. And other times, I think the feelings that are evoked in us as therapists, like I've been saying, I think they have to do with people in their own life. Who are we becoming for them, and be thinking about that. So I think these are not, like, I had read a reading my supervisor had passed me, which was about counter transference, and Amy Reich was her name. Annie Reich. Annie Reich spoke about acting out, that we feel something as therapists and then we act out, that I came in 10 minutes later. And I think the problem with the understanding that we act out, or, oh, I feel angry and I need to do something differently, is that it makes us feel like these are bad things. But these are not bad things. These are things that we need to understand are a repetition of things that have happened in the patient's life outside, which are happening with me. Something as simple as me opening the door for her. And you use that moment to help the patient realize how they're dealing with their people outside the clinic. I think there was one.
Is there one more question? Okay, Dr. Benny would like to ask a final question. Dr. Benny, please go ahead.
Ma'am, I have one genuine question. In the
Yeah.
clinical setup, when we go through with the senior faculties, or maybe a intern with a supervisor, automatically we see a lot of tantrums shown by the supervisor. How do the intern should address these matters? For example, we are seeing a patient. The patient is having some challenge, but sometimes supervisor is not ready to listen to that challenge faced by the client, but gives resolutions. And the interns feel that the supervisor is not listening properly to the client or the bystanders. Then how should the interns who are with the supervisor should react later stage? Thank you.
Could I clarify what you're saying? Are you asking me if?
Yes, ma'am. Yes, ma'am. How should intern react to the supervisor's so-called tantrums?
So if the supervisor is not able to look at the experience that the therapist is having,
Yes.
So I think the work
Now, why
that
I'm saying, myself is a doctor. I am a clinical psychologist working in Oman. And I have been felt this. My juniors are feeling that, but nobody says anything back. And I also feel bad sometimes. So I just want to know how should be the interns' reaction, or what should be the amicable method that interns may say to the supervisor on a later stage. It's only for the student to understand. Thank you.
So I know not all supervisors work in this capacity. Actually, I've always worked with either senior psychoanalytic therapists or psychoanalysts, and I think what I end up doing in my practice is that I and a lot of the colleagues that I've had, I mostly provide psychodynamic psychotherapy, but I have had colleagues who use that particular setting to think about the experience with the help of the supervisor and think about what could be done differently. So I think at the moment, I think it's hard for me to answer because I feel like maybe working alongside, even if you're working, providing a different kind of therapy, working alongside somebody who works with experiences and who works experientially might be helpful, because then they can help you use the relationship as well. But I think, that's a Very good question, because I'm also feeling stuck. I'm trying to think with you, Dr. Benny, and I'm trying to understand how things could be done differently. The only thing at the moment that I'm able to come up with is to be maybe find a different person who could help you use your own experiences as well, if you're interested in that kind of work. Otherwise, I think if the supervisor is not using the experience, then I think maybe we can still try and trust where the supervisor is coming from and the kind of therapy that they're providing, the kind of skills that they're wanting you to do. I think maybe be patient with that. But I think if you're interested in using your experience, then maybe get in touch with the psychoanalyst or a psychoanalytic therapist. And I have figured, I used to feel like clinical psychologists, psychoanalysts may not work with us. I don't know why. I used to feel like psychoanalysts might not work, but they've always felt like no matter which stream of line you come from, they want to help you understand what's going on. Even if you do, like for instance, with the patient that I had, in college who had psychosis, I did a structured therapy, but she still helped me understand the relationship. So I think, yeah, you can, if you'd like to use your experiences, you can find supervisors who can help you use your experience.
See, ma'am, we
Yeah.
are working for a patient from different dimensions.
Yeah.
See, the wholeness comes when the two work together. If we work differently, how does the effect be positive? It's a partial. See, we are seeing an elephant from different parts.
Yeah.
If everybody come together, that's what my opinion. Whether the social worker, psychiatric, or the clinical psycho, or the psychiatrist or neurologist, who are coming from different fields and working together, if they are together at a time where for a patient, then automatically it may be good. It may not be necessary that you should be in the room of the patient itself. I'm just suggesting. But this also should be the future endeavors of ours, because we cannot work independently in our sectors, because we
Yeah.
are only partial. There is a
Yeah,
big need. All should be done. Okay, thank you very much. Good section.
Thank you, Dr. Benny. I really liked your last comment that where this is something that I found really useful, and I'm glad that you brought it up. That each of us, when we work, like for instance, if there's a psychiatric social worker, a clinical psychologist, a psychiatrist, I think each of us, when we work, we provide a different kind of help, and we've been trained in different ways, and our experiences are different. So we actually need to work together. And thank you. I really agreed with that. And
Thank you, Shreya ma'am. I feel we have come, like all the answers have been given. I feel our participants have gotten their questions and doubts clear. Uh, uh, I have to inform that Manisha ma'am is on her way and she has sent her gratitude for the today's webinar. And I would like to invite Bhupendra sir for concluding the session and for giving vote of thanks. Bhupendra sir.
Thank you. Simmy, thank you so much. Yes, obviously it was a very good session. And Shreya, you started from your experiences, then you moved to the overall clinical practices, and you covered in a very nicer. And I think that probably people who are in the practice, they may felt like you are covering their own concept. Most of them, those who are facing the difficulties, the few things are very. Many time I felt that yes, you are covering their own concept. Concepting are making the things in a very impressive and easier for the people, those who are in the practice. It is not very much in the fashion that people don't even want to discuss their cases with their colleagues and all. So it would be a very good idea if they will start to this supervision and the discussion and the case presentation technique. So thank you so much for putting this conceptualization in the clinical practice. And I'm expecting that everyone, because most of us are here clinical practitioners, either in any field, but we are somewhere connected with the patients, with the families, and in the communities. So I'm just expecting that everyone would be benefited from your presentation. And as time is over, so I would like to start. I wanted to talk on your presentation, but that is not permitting me. So I'm just moving ahead for the thanking all the seniors, and I would like to start with Manisha ma'am, who taken charge and leading all the concepts which were that. Although it was the concept was came from the two of our seniors, like Simmy rightly mentioned, that Manisha and Himanshu sir. And it is going on with the effort of the current PhD scholars of RINPAS, Vikas, Swati, and few other, those who are over there. They are promptly working. And I must say that they are working very hard to make it continue in the supervision of Manisha ma'am. So for today, I would like to thank, first of all, our speaker of the day, Shreya. Thank you so much for being with us and giving us the insightful session and very informative presentation. Thank you so much for joining us.
Yeah.
Thank you.
And I would like to thank Simmy for a very expressive and good expression for her thoughts and introducing everyone, including our speaker, including Manisha ma'am, and that very carefully she picked most of the comments, questions, and all these things for today's session. So credit goes to her for this successful completion of this today's session. Thank you so much, Simmy, for joining us and making this session very effective.
Thank you so much, sir. It's been an honor.
Proud that I'm also the part of that same family from where that this very keen and you can say that impressive people, those who are going up. I really many times feel very happy to be part and alumni of RINPAS. And yes, I would like to thank Vikas for taking all the major responsibility with his colleagues. I'm not able to take all the names, so please consider that I am considering all the PhD and yes, also those working very hard to make all these programs successful. Thanks to all my seniors and especially to Manisha ma'am for making it happen and possible. And yes, obviously, I would like to again thank all my friends, those who spared their time, joined, and make this webinar, this series successful. Thank you, one and all. Thank you so much. And yes, obviously, special thanks to Dhirendra Patel. He's regular means attending, I think, from the first one to till without any failure.
Thank you, sir.
So, one and all, I would like to thanks again. Thank you so much.
Thank you so much, sir. Concluding, I would also like to thank Dr. Manisha ma'am, Shreya ma'am for coming. I would like to inform that we invited Shreya ma'am at the last moment. Our speaker was purposely planned for today's session, was sick, and I invited her. She did not even blink her eyes to say yes, and she was very excited to take the session in the last moment. Thank you so much, Shreya ma'am. It would not have been possible without you. Also, thanking the audience for the active participation. Hopefully, the presentation will be beneficial for everyone. Thank you for your time. We'll try to come more motivating topics and thank you again joining us today. See you next time. Also, we wish everyone happy Navratri. Thank you so much.
Thank you.